Imagine for a moment the incredible feat that is the formation of a tiny human heart, taking shape, adapting, and getting ready for its big entrance into the world. It truly is one of life's most profound miracles.
It really is.
But sometimes, in this miraculous journey, a baby's heart takes a few unexpected detours.
And that's exactly what we're here to explore today.
Hmm.
We're taking a deep dive into congenital heart diseases. These are conditions that are present right at birth, affecting the heart structure and, well, how well it functions.
Yeah, our mission today is to really cut through some of the medical jargon and give you the essential insights into fetal heart development and these common congenital heart conditions.
hmm
We'll try to unravel how a baby's circulation changes so dramatically at birth, learn to tell the difference between, harmless heart sounds and maybe more significant issues,
Mm,
and really understand what happens when these crucial changes don't go as planned. It's about arming you with the vital knowledge quickly and clearly.
exactly. Getting you well informed.
So let's embark on this journey, starting with the heart's first highway, normal fetal circulation and early sounds. Before a baby is born, their lungs aren't doing the breathing work. That's all mom's job, right?
That's absolutely right. So the fetal circulatory system has this really ingenious temporary bypass network in place.
Okay.
In normal fetal circulation, blood largely bypasses the lungs. Think of the heart maybe as a four-room house with a series of, let's say, special doors that open and close at just the right time.
Mm-hmm.
There are two critical temporary openings, or shunts, that make this lung bypass possible. First, there's the foramen oval.
Okay, the foramen oval.
Yeah, this is like a temporary trapdoor between the upper chambers of the heart, the right atrium and the left atrium. About two-thirds of the blood coming into the right atrium actually gets shunted directly across to the left atrium through this opening.
Wow, two-thirds, so it just skips the lungs entirely.
Skips the lungs, exactly. It's literally rerouting blood away from them.
Fascinating. And that's the second key, shunt.
That would be the ductus arteriosus. This is a small blood vessel that connects the pulmonary artery, that's the big vessel taking blood towards the lungs directly to the aorta, which is the main artery carrying blood away from the heart to the rest of the body.
Ah, okay.
So instead of going to the fetal lungs, which aren't yet working to oxygenate blood, that blood just zips past them and goes straight out to the body.
The critical moment, then, must be birth itself. What actually happens to these bypasses?
Absolutely. That moment, a baby takes its first breath. It triggers this rapid and dramatic shift. The pressure on the left side of the heart suddenly becomes much greater than the pressure on the right.
Okay.
And this pressure change is the signal that promotes the natural closure of both the foramen oval and the ductus arteriosus. They're basically designed to shut down once the lungs take over the job.
That's an incredible adaptation. But what if those bypasses don't close as they should? Or even more surprising, what if doctors sometimes want them to stay open? That sounds kind of counterintuitive.
It does, yeah, and this is where it gets truly crucial, actually. In certain severe cyanotic heart diseases, those are conditions that cause a bluish tint to the skin because the body isn't getting enough oxygen-rich blood.
Right, the blue baby condition.
Exactly. Things like severe coarctation of the aorta, tetralogy of Fallot, or transposition of the great vessels. In these cases, a doctor might deliberately prevent the ductus arteriosus from closing.
So the goal is actually to keep that temporary bypass open. Why?
Precisely. In these specific, very serious conditions, keeping the ductus arteriosus patent, or open, allows oxygenated and deoxygenated blood to mix.
Ah,
And this mixing is absolutely vital because it can significantly improve the baby's oxygen levels, alleviate that severe blueness, until a definitive surgical repair can be performed.
how do they do that?
To do this, medical teams administer specific medications called prostaglandins. A common one is prostaglandin E1 analogs like alprostadil. They essentially tell the ductus to stay open.
Okay. Moving from sort of plumbing to acoustics, let's talk about the sounds of a baby's heart. Parents often hear about murmurs in their children, right? Which can sound scary, but often they're completely harmless.
That's very true. And the most common innocent or physiological murmur of childhood is called Still's murmur.
Still's murmur.
Yeah, Still's murmur is one of those sounds that can sometimes worry parents, but it's typically heard from about 2 months of age until pre-adolescence, and it usually just resolves on its own by early adolescence.
And what causes it?
It's thought to be due to the normal vibration of the heart's valve leaflets as blood flows through. Just a bit of turbulence, really.
And when a doctor listens to it, it has a very distinct sound, doesn't it?
It does. It's often described as musical, vibratory, maybe even noisy or twanging, a low-pitched sound heard during the early to mid part of the heart squeezing phase. That's systole.
Okay.
You usually hear it best at the lower left part of the breastbone and at the apex, the tip of the heart. What's interesting is that it hardly radiates, meaning it doesn't spread much beyond that area.
Mm-hmm.
And it actually gets quieter when the child sits up, stands, or does a Valsalva maneuver, which is like bearing down.
Okay.
But it gets louder when they're lying flat or in what we call hyperdynamic states, like when they have a fever or are anxious and their heart is just working harder.
Got it. And what's the other common innocent one?
The second most common innocent murmur, and notably the most common continuous benign murmur, is the cervical venous hum. This one is typically heard in children between about 2 and 8 years old.
Cervical venous hum. And what's going on inside to create that sound?
It's due to the natural, perfectly normal, turbulent blood flow as it returns to the heart, specifically at the junction where the jugular vein, one of the large veins in the neck, meets the superior vena cava, which brings blood from the upper body into the heart. Just a bit of noisy flow there.
So on examination, how does that sound?
It's a soft, sort of whirling, low-pitched, continuous sound. It's best heard up in the neck, along the left to right sternal borders, or even just below or above the collarbone, especially when the child is sitting upright.
Mm-hmm.
What really helps differentiate it is that it gets louder when the head is extended, but it decreases significantly, or even disappears when the child lies down, or if you put light pressure on the jugular vein in the neck, or when the head is rotated or flexed, or they do that Valsalva maneuver again.
So what does this all mean for you, the listener? These innocent murmurs are usually completely harmless and often just disappear as a child grows.
That's the key takeaway.
But understanding these specific characteristics is incredibly important for healthcare providers, right? It allows them to quickly distinguish these benign sounds from something more significant.
Absolutely. It spares parents unnecessary worry and ensures children get the right care, or sometimes just reassurance. It really showcases the art of listening in medicine.
Okay, let's pivot now to openings and obstructions non-cyanotic conditions. These are conditions that typically involve a left to right shunt.
Right. So this means oxygen-rich blood flows from the left side of the heart, where the pressure is naturally higher, back over to the right side, but crucially without causing that bluish discoloration, that cyanosis we talked about earlier.
Okay, first up.
First up, the patent foramen oval, or PFO. This is essentially that little flap door between the right and left atria, the heart's upper chambers that we mentioned earlier.
Mm-hmm.
Well, sometimes it's covered, but not completely sealed shut after birth.
Right.
And it's important to understand this isn't technically considered an atrioseptal defect because no actual heart tissue is missing. It's simply a flap that didn't fully fuse closed.
And most PFOs are asymptomatic, right? They don't cause any problems for most people.
The vast majority, yes.
Yeah.
But here's where it gets really insightful. Its association with what's called a cryptogenic stroke.
Okay, what's that?
That's a stroke where doctors can't find any other obvious cause.
Yeah.
It can happen because of something called a paradoxical embolism.
Paradoxical embolism.
Yeah, where a small clot from the body's veins travels up, goes through the PFO from the right side to the left side of the heart, completely bypassing the lungs where it might normally get filtered out.
Oh, wow.
And then goes straight up to the brain. It's also been linked, interestingly, to decompression sickness in divers, some types of migraines, and even acute limb ischemia.
So how is it diagnosed?
Diagnosis for a PFO is best done with an echocardiogram. That's an ultrasound of the heart. A transthoracic echo, where the probe is on the chest, is usually the first step. Though a transesophageal echo, where the probe goes down the throat, is actually more sensitive for detecting smaller PFOs.
And management, if it's found?
Well, management options range from percutaneous device closure, using a catheter to place a small device, to physically close the opening to surgical closure. For those who had a cryptogenic stroke, antiplatelet medications or anticoagulants are often prescribed to prevent future clots.
Okay. Next, let's look at the atrial septal defect, or ASD. Now, if a PFO is like a temporary trapdoor that just doesn't quite seal, an ASD is more like a permanent hole, right? A window left open in the wall between the heart's upper rooms, the atria.
That's a good way to put it. It's an abnormal opening in the atrial septum, allowing for that left to right shunt.
Are there different types?
Yes, there are a few types.
Yeah.
The most common is the ostium secundum type. That accounts for maybe 75 to 80% of cases. Less common is the ostium primum, around 15 to 20%, which is often associated with abnormalities of the heart valves nearby, particularly the mitral valve.
Okay.
Then you have rarer types like sinus venosus and coronary sinus defects.
Clinically, it's quite interesting because most patients, especially kids, are asymptomatic or have really minimal symptoms. Problems often don't show up until maybe their 30s or even later.
That's true. Although in infants and young children, a significant ASD might show up as recurrent respiratory infections. Maybe failure to thrive, meaning they're not gaining weight properly, or exertional dyspnea, shortness of breath with activity.
Right.
And then as adolescents or adults, symptoms might include easy fatigability, palpitations, abnormal heart rhythms like atrial arrhythmias, fainting spells, or even heart failure later on. And yes, that risk of paradoxical emboli is still there.
What about the physical exam? What does a doctor hear?
Well, what truly stands out is often a soft, systolic ejection crescendo-decrescendo flow murmur over the pulmonic area. That's the upper left part of the breastbone near the second rib.
Okay.
But the hallmark finding for an ASD, the real classic sign, is a wide, fixed split S2.
Wide, fixed split S2. What does that mean?
It means that the two components of the second heart sound, normally heard as a single dub, are persistently separated. And crucially, they don't change with breathing, which is highly unusual. Normally, those sounds vary a bit with respiration.
Ah, okay.
You might also hear a loud first heart sound and feel a hyperdynamic right ventricle. The right lower chamber is working harder and pulsating strongly. And in very severe, long-standing cases, you can get into that Eisenmenger syndrome territory again.
Where the shunt reverses.
Exactly. High blood flow to the lungs causes irreversible lung vessel damage. Pressure on the right side goes way up, and the shunt reverses, leading to cyanosis and clubbing.
So how do doctors confirm this ASD?
Diagnosis usually starts with a transthoracic echocardiography with Doppler. It gives real-time images of blood flow and shows the hole. An ECG, or electrocardiogram, might show an incomplete right bundle branch block, a specific electrical pattern, or sometimes something called a crochetage sign, which is a little notch on the QRS complex in certain leads. A chest X-ray might reveal an enlarged heart and increased blood flow markings in the lungs.
And for management, what's done?
Those small ASDs, typically less than 5 millimeters, can often be simply observed, as many will actually close spontaneously within the first year of life.
Oh, okay.
But if the defect is larger than 1 centimeter, or if the patient is symptomatic, surgical correction is usually recommended, ideally between 2 and 4 years of age. This can be done either with a less invasive percutaneous transcatheter closure, threading a device through a vessel to plug the hole, or with traditional open-heart surgical repair.
Okay, next condition. Patent ductus arteriosus, or PDA. This is that persistent open connection between the descending thoracic aorta and the main pulmonary artery, right? The fetal bypass, the ductus arteriosus, just failed to close completely after birth.
Exactly. And there are some clear risk factors for this. It's more common in premature infants, especially those weighing less than 1,000 grams at birth. It's also twice as common in females.
Interesting. Any others?
Yeah, other associated risks include fetal hypoxia, low oxygen levels in the womb, in utero alcohol exposure, and congenital rubella infection during pregnancy.
So normally that ductus closes pretty quickly after birth. What goes wrong in PDA?
Well, normally after a baby's first breath, there's a decrease in the resistance to blood flow in the lungs. This, along with the release of a substance called brodiocanin and just higher oxygen levels in the blood, signals the ductus to constrict and close. But in PDA, continued production of prostaglandins, especially prostaglandin E2, and sometimes low oxygen levels in the baby, can keep that ductus open. And a large PDA can lead to significant left-to-right shunting of blood, which increases blood flow to the lungs and makes the heart work much harder.
What does that look like in a baby then?
Most patients with a small PDA are actually asymptomatic. But if it's larger, infants might show signs like poor feeding, poor weight gain, maybe frequent lower respiratory tract infections, or signs of pulmonary congestion like heavy or fast breathing. They might also tire easily or even rarely develop endocarditis, which is an infection of the heart lining. And again, like ASD, in severe long-standing cases, the continued high blood flow to the lungs can lead to Eisenmenger syndrome with shunt reversal, cyanosis, and clubbing.
Okay, the physical exam for PDA is pretty famous, isn't it? The murmur.
Oh yeah, the classic finding is very distinctive. The continuous machine-like or to and fro murmur, like an old washing machine, or maybe a train going through a tunnel. It's continuous through systole and diastole.
Wow. Where do you hear it best?
It's loudest at the pulmonic area, the upper left part of the chest, just below the collarbone, and it might even radiate to the back. You'll also typically find a wide pulse pressure. The difference between the top and bottom blood pressure numbers is greater than 30 millimole HEV.
Okay.
Bounding peripheral pulses, where you can feel the pulse really strongly in the arms and legs, and a prominent precordial impulse, where you can see or feel the heart beating strongly against the chest wall.
Diagnosis? Echo again.
Echo is the best initial test, yes. It will clearly show the open ductus and the blood flow through it. An ECG might show enlargement of the left ventricle or left atrium, and a chest X-ray can be normal or show an enlarged heart.
How is PDA managed?
Well, for asymptomatic infants weighing over 1,000 grams, they're often just observed closely, as many PDAs will close spontaneously. But for symptomatic preterm infants, a class of medications called NSAIDs, like indomethacin or ibuprofen or even acetaminophen sometimes, are often the first-line treatment.
How do those work?
These drugs interfere with prostaglandin synthesis. They basically remove the chemical signal that's keeping the ductus open, and that helps promote its closure.
Makes sense. And if that doesn't work?
Then surgical correction, either a percutaneous catheter occlusion, placing a device to block the opening via a catheter or surgical ligation, where the ductus is literally tied off, is reserved for PDAs that are causing significant problems and don't respond to medication. Ideally, this intervention is performed before 1 to 3 years of age to prevent long-term issues.
All right, moving on. Coarctation of the aorta, or CoA. This is different. It's a congenital narrowing of the aorta itself, the body's main artery.
That's right, and is most commonly found at a specific spot, usually just after where the ductus arteriosus connects, and just beyond the origin of the left subclavian artery, which supplies blood to the left arm.
Are there things often associated with CoA?
Yes, definitely.
Okay.
About 70% of patients with CoA also have a bicuspid aortic valve, meaning their aortic valve has 2 leaflets instead of the usual 3.
Wow, 70%.
Yeah, it's a very strong association. It can also be linked with other heart defects like mitral valve issues or a PDA. And here's a really crucial point. Between 5 and 15% of girls diagnosed with CoA also have Turner syndrome, a genetic condition. So karyotype screening a test for chromosome abnormalities is often recommended for girls with CoA.
Okay, so what's the mechanism? How does this narrowing cause problems?
The pathophysiology is quite direct. This narrowing acts like a kink in a garden hose. It results in hypertension, high blood pressure in the arteries before the narrowed segment, like in the arms, and relatively low blood pressure or hypotension after the narrowing, so down in the lower extremities, the legs. The body tries to compensate for this obstruction by developing collateral circulation, essentially creating new bypass routes for blood, often using the intercostal arteries which run along the ribs.
Interesting. Are there different types?
Yeah, traditionally described as postductal, often called the adult type, where the narrowing is distal to the ductus arteriosus insertion, and preductal, the infantile type, where it's proximal. Although the location relative to the ductus is key.
And symptoms.
Most patients are actually asymptomatic, especially if the coarctation is mild. In adults, hypertension, maybe presenting with headaches or nosebleeds, is the most common symptom.
Okay.
Other potential issues include intracranial aneurysms, weakened blood vessels in the brain, or bilateral claudication, which is leg pain with exercise due to poor blood flow. They might also experience shortness of breath with exertion, exercise intolerance, fatigue, or fainting.
And in babies?
Neonates, however, might present with more acute issues like failure to thrive or poor feeding, usually 1 to 2 weeks after birth, especially as the ductus arteriosus begins to close naturally and that obstruction becomes much more critical.
So the key physical exam finding reflects that pressure difference, right?
Exactly. The absolute key finding is upper extremity systolic hypertension with lower extremity hypotension. That means the blood pressure in the right arm is often significantly higher, say more than 10 mmHg, than in the right leg. You'll also find diminished or delayed pulses in the lower extremities. The femoral pulses in the groin or the pulses in the feet might be weak or late compared to the arm pulses.
Is there a murmur?
Yes, usually a systolic murmur heard along the left sternal border that radiates to the back, often best heard between the shoulder blades.
Diagnosis. Still echo.
Echo is usually confirmatory, yeah. It can directly visualize the aortic narrowing. A chest X-ray might show some classic signs like posterior rib notching, which are literally erosion marks on the underside of the ribs caused by those enlarged collateral intercostal arteries working overtime. You might also see a figure 3 sign, where the indentation of the aorta and the poststenotic dilation creates a shape resembling the number 3 on the X-ray. An ECG might show left ventricular hypertrophy as the left side of the heart works harder against the obstruction. Angiography, a detailed X-ray of the blood vessels using dye, is considered the gold standard for the full assessment, though.
And management for CoA.
Management typically involves corrective surgery or a transcatheter intervention, like balloon angioplasty with or without stenting, ideally performed in early childhood to prevent long-term hypertension.
Hmm.
And critically, for neonates presenting with severe symptoms, especially before surgery, prostaglandin E1 or Prostadil is crucial.
To keep the ductus open again.
Exactly. It's given intravenously to maintain a patent ductus arteriosus, which helps stabilize the baby by allowing some blood flow to bypass the severe coarctation and reach the lower body, reducing symptoms until repair.
Okay. And finally, for our non-cyanotic conditions, we have the ventricular septal defect, or VSD. This is pretty simply a hole in the ventricular septum, the muscular wall separating the two lower chambers of the heart, the ventricles.
That's right. And it usually results in a left to right shunt, again because pressure is higher on the left side.
And this is the most common one overall, right?
It is the most common type of congenital heart disease found in childhood, yes. Small to moderate defects typically maintain that left to right shunt. However, here's a crucial point. Large, unrestricted defects, if left untreated for a long time, might eventually cause so much extra blood flow to the lungs that it leads to irreversible damage to the pulmonary blood vessels.
And that leads...
That can reverse the shunt, causing blood to flow from right to left, leading back to Eisenmenger syndrome and cyanosis.
Okay. Are there different types of VSDs?
Yes, several types based on their location in the septum. The membranous type is the most common, maybe 80% of cases, located high up in the septum. Then there are muscular VSDs, which can be multiple small holes, sometimes called a Swiss cheese septum. AV canal or inlet VSDs are located lower down near the tricuspid and mitral valves.
Yeah.
And supracrystal or outlet VSDs are located up near the aortic and pulmonary valves.
Do they behave differently?
Well, the supracrystal type, for example, rarely closes spontaneously and is often associated with problems with the aortic valve, like prolapse or insufficiency. Muscular VSDs often close on their own.
Clinically, how do they present?
Small VSDs, which are often called restrictive because they limit flow, are often asymptomatic or cause only mild symptoms. They're usually discovered instantly during a routine checkup just by hearing the murmur. Moderate VSDs can present with signs like excessive sweating or fatigue, especially during feeding. Feeding is hard work for these babies. Also poor feeding, inadequate growth, or frequent respiratory infections because of that extra blood flow to the lungs. You might also see rapid breathing, a fast heart rate, maybe an enlarged liver, or mild signs of heart failure.
And large ones.
Large unrestricted VSDs, where there's basically no pressure difference between the ventricles, cause more severe symptoms. They often lead to failure to thrive or significant heart failure signs, sometimes as early as 3 to 4 weeks of age.
And if it progresses to Eisenmenger?
Then you'll see that pronounced cyanosis, shortness of breath, fainting spells, and clubbing of the fingers and toes. Interestingly, in these very severe Eisenmenger cases, the typical loud VSD murmur might actually disappear because the shunt is reversed or equalized, but you might hear a very loud pulmonic component of the second heart sound due to the high pulmonary pressure.
Okay. The murmur for a typical VSD is also quite distinct, isn't it?
Yes, you'll typically hear a high-pitched, harsh, holosystolic murmur. Holosystolic means it's heard throughout the entire squeezing phase of the heart, systole.
Where is it best heard?
Usually best heard at the third or fourth intercostal spaces along the lower left part of the breastbone. And here's a slightly counterintuitive thing.
Yeah.
Smaller VSDs are paradoxically often louder and have more palpable thrills, that vibration you can feel on the chest, than larger ones.
Why is that?
Because the smaller hole creates more turbulence as the blood jets through under high pressure from left to right. A huge hole might have less turbulent flow. You might also sometimes hear a diastolic rumble at the mitral area due to the increased blood flow returning from the lungs and crossing the mitral valve.
And what about that hand grip maneuver?
Ah, yes. What's truly insightful here for diagnosis is the hand grip maneuver. If the patient squeezes their hands tightly, it actually increases the murmur's intensity.
Wait.
Because hand squeezing increases the resistance in the systemic blood vessels, what we call afterload. This makes it harder for blood to flow out of the left ventricle into the aorta, so it effectively pushes more blood across the VSD from left to right, making that murmur louder.
Clever. Diagnosis confirmation.
Again, echocardiogram is the way to go. It accurately determines the size and location of the VSD and assesses the degree of shunting. An ECG might show left ventricular hypertrophy in mild to moderate disease, or sometimes a combined right and left ventricular hypertrophy, which has a specific pattern called the Katz-Wachtel phenomenon seen in larger defects. A shaped X-ray may be normal, Or it could show left atrial enlargement or right ventricular hypertrophy, depending on the size and effects of the VSD.
And how are VSDs managed?
Well, for small asymptomatic VSDs, they're usually just observed closely as a good number, especially muscular ones, close spontaneously within the first 12 months or so. But if a baby is symptomatic, or if they have uncontrolled heart failure, growth delays, or recurrent respiratory infections, patch closure of the VSD is recommended. For large shunts, repair is typically done by 2 years of age to prevent the development of irreversible pulmonary hypertension, that Eisenmenger physiology.
All right, let's shift gears now to the blue baby condition cyanotic heart diseases. These conditions are characterized by a right-to-left shunting of blood.
Exactly. This means deoxygenated blood that hasn't picked up oxygen from the lungs, is bypassing the lungs and going directly out into the systemic circulation. This leads to cyanosis, that characteristic bluish discoloration of the skin, lips, and nail beds. It's a very visible sign that the body isn't getting enough oxygen.
And there's a common way to remember the main types, right? The 5 Ts.
That's right. It's a helpful mnemonic, the 5 Ts, to keep track of the 5 main types of cyanotic congenital heart disease.
Okay, let's list them.
First T is truncus arteriosus. This is where, instead of 2 separate great vessels leaving the heart, the aorta and pulmonary artery, there's just one single large vessel, the truncus, doing both jobs.
One vessel instead of 2. Got it.
Second T is transposition of the great arteries. Here you have 2 vessels, but they're switched. The aorta comes off the right ventricle and the pulmonary artery comes off the left ventricle. We'll talk more about that one.
Okay. Third T.
Tricuspid atresia. Atresia means absence. So this is the absence of the tricuspid valve, leading to a hypoplastic or severely underdeveloped right ventricle. For survival, an ASD, and usually a VSD, must be present to allow blood to get to the lungs somehow.
Right, need those connections. Fourth.
The fourth T is tetralogy of Fellot. This involves 4 specific problems, hence tetralogy. We'll dive into this one too.
Okay. And the fifth T.
Total anomalous pulmonary venous return, or TAPVR. In this condition, all 4 pulmonary veins, which should bring oxygenated blood back to the left atrium, instead connect abnormally, often draining together into the right atrium or one of its tributaries, like the superior vena cava. So oxygenated blood goes back to the right side instead of the left.
Wow. Okay. And you mentioned there are others besides the 5 Ts.
Yes, we should also briefly mention hypoplastic left heart syndrome, which we touched on, involving underdevelopment of the left side of the heart, and pulmonary atresia, a complete blockage of the pulmonary valve, as other significant cyanotic conditions.
Okay, let's take a deep dive now into tetralogy of Fallot, or TOF. You said this is the most common cyanotic congenital heart disease.
Yes, it is. And it's not just one defect, but a specific constellation of 4 problems happening together.
The tetralogy. What are the 4?
Okay, number 1, right ventricular outflow tract obstruction, often due to pulmonary valve stenosis, basically a narrowing that blocks blood flow from the right ventricle to the lungs. Number 2, right ventricular hypertrophy, meaning the right lower heart chamber muscle gets very thickened from having to push against that obstruction.
Makes sense.
Number 3, a large unrestricted VSD, that hole between the lower chambers. And number 4, an overriding aorta, where the aorta, the main artery to the body, sits shifted over directly above the VSD, allowing it to receive deoxygenated blood directly from the right ventricle, as well as oxygenated blood from the left.
Okay, 4 components. How does this present?
Well, in infancy, cyanosis, the blue baby syndrome, is the most common presentation, sometimes along with poor feeding or rapid breathing. Older children may experience shortness of breath with exertion, and the cyanosis often worsens as they grow. But here's where it gets truly unique and fascinating. TET spells.
TET spells. What are those?
These are sudden, frightening episodes of profound cyanosis, often triggered by crying, feeding, or agitation. The baby becomes very blue, irritable, and may gasp for air. But remarkably, these spells can often be relieved, sometimes dramatically, by squatting.
Squatting? Why on earth would squatting help a blue baby?
It's actually quite ingenious physiology. When an older child squats down, or when parents put an infant into a knee-chest position, it kinks the arteries in the legs, significantly increasing the resistance in the systemic blood vessels, the body's circulation. This higher systemic resistance makes it harder for the deoxygenated blood from the right ventricle to flow across the VSD into the overriding aorta and bypass the lungs.
Ah, so it changes the path of least resistance.
Exactly. It forces more of that blue blood to go to the narrowed pulmonary artery route and into the lungs to pick up oxygen. This improves oxygenation and reduces the cyanosis, breaking this spell. It's quite remarkable.
That is fascinating. What about the physical exam for TOF?
On exam, you'll typically hear a harsh systolic ejection murmur, usually at the left mid to upper sternal border. Interestingly, this murmur is primarily from the VSD, not the pulmonary stenosis. You might also feel a right ventricular heave, that forceful pulsation from the thickened right ventricle. Digital clubbing thickening of the fingertips and cyanosis are common visual signs. And there's often a loud, single-second heart sound, S2, because the pulmonary valve closure sound, P2, is often very soft or absent due to the obstruction. A systolic thrill, that vibration on the chest, might also be palpable.
How is TOF diagnosed definitively?
Diagnosis of TOF is best established with an echocardiogram. It will clearly show all four defects: the VSD, the RV outflow obstruction, the RV hypertrophy, and the overriding aorta. Many infants with TOF are actually diagnosed prenatally nowadays through detailed fetal ultrasounds.
Okay. What about X-ray?
A chest X-ray often shows a very distinctive boot-shaped heart.
Booch.
Yes, the thickened right ventricle causes the apex of the heart to be upturned, and the area where the main pulmonary artery should be looks concave or indented because it's underdeveloped. So the heart silhouette looks like a wooden shoe or a boot. The overall heart size itself is often normal, though, and the lung markings might look normal or even decreased.
And ECG?
An ECG typically reveals signs of right ventricular hypertrophy, often right atrial enlargement as well, and what's called right axis deviation in the heart's electrical activity.
Okay, so management. What's the approach for TOF?
Well, for neonates born with very severe right ventricular outflow tract obstruction, they might need intravenous prostaglandin therapy, specifically alprostedol, right away.
To keep the ductus open.
Exactly, to keep the ductus arteriosus patent. This provides a reliable pathway for blood to get to the lungs until a more definitive repair can be done. Sometimes they might also need ductal stenting or a temporary palliative shunt procedure as a bridge to full repair.
And the full repair?
Surgical repair is the definitive management, ideally performed in the first year of life, often between 3 and 6 months old, depending on the baby's condition. The surgery involves closing the VSD with a patch and enlarging the right ventricular outflow tract to relieve the obstruction, often widening the pulmonary valve or artery.
Any medical management before surgery?
Sometimes beta blockers like propranolol can be used before surgery to try and decrease the frequency or severity of those TET spells.
And if a TET spell happens, what's the emergency treatment?
Yeah, managing an acute TET spell is critical. The stepwise management usually includes, first, putting infants in that knee-chest position or having older children squat, then giving supplemental oxygen. Medications often include IV morphine to calm the baby and reduce respiratory drive, an IV fluid bolus to increase preload, then IV beta blockers like propranolol or esmolol to relax the outflow tract spasm. And if symptoms still persist, sometimes IV phenylephrine is used to increase systemic vascular resistance, mimicking the squatting effect. It's a very urgent situation requiring prompt action.
Okay, let's move to the next T. Transposition of the great arteries, or TGA. You said this is where the aorta and pulmonary artery are switched.
That's right. It's a critical condition involving discordance between the aorta and pulmonary trunk. So the aorta arises from the right ventricle, and the pulmonary trunk arises from the left ventricle. This is the most common cyanotic heart disease presenting right in the neonatal period, specifically the dextro-TGA type.
So instead of the normal crisscross pattern, it creates two completely separate parallel circuits of blood flow, which sounds bad.
It's extremely problematic, yes.
Yeah.
In dextro-TGA, or DTGA, which is the most common type, you have these two parallel ineffective circuits. Deoxygenated systolic blood returns from the body to the right side of the heart, gets pumped by the right ventricle, right back into the systemic circulation via the aorta without ever going to the lungs.
So blue blood goes to the body.
Exactly. Meanwhile, oxygenated blood from the lungs returns to the left side of the heart, gets pumped by the left ventricle, right back to the lungs via the pulmonary artery, so red blood just keeps circling through the lungs.
That can't sustain life.
Not on its own, no. Survival before surgical correction absolutely depends on the presence of connections between these two circuits, like a PDA, an ASD, or a VSD, to allow for some mixing of oxygenated and deoxygenated blood. Without mixing, it's fatal very quickly.
You mentioned DTGA. Is there another type?
Yes, there's also levo-TGA, or LTGA, sometimes called congenitally corrected TGA. This is anatomically complex, but functionally it's usually acyanotic initially. Basically, the ventricles are switched too. The right atrium sends blood to the morphologic left ventricle, which happens to be on the right side, and this ventricle correctly sends blood to the pulmonary system. Conversely, the left atrium sends blood to the morphologic right ventricle, which is on the left side, and this ventricle sends blood to the systemic circulation.
So it kind of works initially.
It works, but the morphologic right ventricle isn't designed for the high-pressure work of pumping blood to the whole body. So patients with LTGA are typically unaffected early in life, but eventually that right ventricle struggles and fails, and they present with heart failure, usually later in adulthood.
Okay, back to the more common and immediately critical DTGA. What are the key clinical manifestations?
In DTGA, severe cyanosis and rapid breathing, tachypnea, are typical within the first few hours or days of life, often within the first 30 days. Crucially, these symptoms, especially the cyanosis, are not significantly affected by exertion or giving the baby 100% supplemental oxygen. That lack of response to oxygen is a major diagnostic clue,
Why doesn't oxygen help?
because the problem isn't getting oxygen into the blood in the lungs. The lungs are working fine. The problem is that the oxygenated blood isn't getting out to the body.
Got it.
The degree of cyanosis depends entirely on how much mixing occurs between those two parallel circuits, which is influenced by the size of any existing ASD, VSD, or PDA. Interestingly, despite the rapid breathing, these babies often appear surprisingly comfortable, not distressed. Sweating and poor feeding can also be seen.
What about the physical exam? What would a doctor find?
Central cyanosis is very prominent, obviously. You'll typically hear a loud and single-second heart sound, S2. This is because the aortic valve is now anterior and closes forcefully, while the pulmonary valve is posterior and its sound is often muffled or inaudible. Murmurs are not usually present unless there's an associated VSD or perhaps some pulmonic stenosis.
Diagnosis relies heavily on.
Echocardiogram. It's the primary means of diagnosis and very clearly shows the abnormal origins of the great arteries. An ECG might be normal initially, or it might show right axis deviation or signs of right ventricular hypertrophy, because the RV is now the systemic ventricle. And the chest X-ray often shows that characteristic egg on a string appearance.
Egg on a string.
Yeah, the heart often looks enlarged and globular, like an egg lying on its side.
Yeah.
And the superior mediastinum, the area above the heart where the thymus and great vessels sit, often looks narrow because the great arteries are lined differently, and the thymus gland might be small due to stress. This combination creates that egg on a string visual. It's quite suggestive.
Management sounds urgent.
Extremely urgent. Initial management for DTGA focuses on ensuring adequate oxygenation by improving the mixing between the two circuits. This means starting prostaglandin E1 administration, alprostadil, again immediately, to keep that ductus arteriosus open.
Right, that connection is vital.
Absolutely vital, and often a balloon atrial septostomy is performed soon after birth. This is a catheter-based procedure where a balloon is inflated across the foramen oval to tear the atrial septum and create or enlarge an ASD, allowing better mixing at the atrial level.
And then surgery.
Yes, once the baby is stabilized, corrective surgery, specifically an arterial switch operation, is performed, usually within the first week or two of life. This complex surgery involves transecting the aorta and pulmonary artery, switching them back to their correct ventricles, and importantly, also moving the coronary arteries over to the new aorta.
Wow. And the prognosis?
Without treatment, tragically, about 90% of affected children die by 1 year of age. But with successful early arterial switch surgery, the 5-year survival rate is now excellent, over 80%, often much higher in experienced centers. It's a true surgical marvel.
Okay, let's briefly touch on the remaining cyanotic conditions. Pulmonary atresia. What's the core issue there?
Pulmonary atresia means a complete obstruction to right ventricular outflow. Blood literally cannot flow from the right ventricle into the pulmonary artery and then to the lungs to get oxygenated because the pulmonary valve is completely blocked or absent. There are different anatomical types, valvular or muscular, and it often comes with varying degrees of underdevelopment of the right ventricle and tricuspid valve.
So how does blood get to the lungs at all?
Survival depends entirely on the ductus arteriosus remaining open, providing the only route for blood to get from the aorta into the pulmonary arteries and then to the lungs.
So cyanosis is severe.
Yes, significant cyanosis due to right-to-left shunting, usually at the atrial level through a PFO or ASD. You'll often hear a single S2 heart sound because only the aortic valve is functional, and possibly a systolic murmur if the tricuspid valve is leaky. Regurgitation.
Management starts with
Prostaglandins. Maintaining the patency of the ductus arteriosus with a prostaglandin E1 analog like alprostadil is life-saving to stabilize the infant initially. A balloon atrial septostomy might also be needed to improve mixing. Definitive treatment involves complex surgical repair, often staged.
Next, tricuspid atresia. This is the absence of the tricuspid valve.
Exactly. Absence of the tricuspid valve, the valve between the right atrium and right ventricle. This inevitably leads to a hypoplastic or severely underdeveloped right ventricle because blood can't enter it properly.
So how does blood circulate?
All the systemic venous blood returning to the right atrium must cross through an ASD or PFO to the left atrium to mix with oxygenated blood. From the left ventricle, some blood goes to the body via the aorta, and some must find a way to the lungs, usually either through a VSD allowing flow from the left ventricle to the rudimentary right ventricle out a pulmonary artery, or via a PDA. So a PDA or a VSD is absolutely necessary for pulmonary blood flow and survival.
Clinical picture.
Significant cyanosis due to that obligatory right-to-left shunting and mixing. Survival is improved if a PDA is present. Like pulmonary atresia, you'll often hear a single S2 heart sound. Diagnosis often shows left ventricular hypertrophy on ECG, which is unusual for a right-sided heart problem, but makes sense here because the LV is doing all the work. Chest X-ray might show a normal or enlarged heart with decreased pulmonary blood flow markings.
Management again relies on
Maintaining ductus patency with alprostadil is key initially. The presence of a VSD can help improve oxygenation. Surgical repair is definitive and typically involves a staged approach, similar to other single ventricle conditions, ultimately aiming to connect systemic venous return directly to the pulmonary arteries. Fontan procedure.
And finally, hyperplastic left heart syndrome, HLHS. We touched on this, but summarize the core issue.
HLHS involves the severe underdevelopment or failure of development of multiple critical left-sided heart structures. This could be the mitral valve, the aortic valve, the ascending aorta, or the left ventricle itself. The result is a left ventricle that is far too small or completely non-functional, unable to support the systemic circulation. It accounts for about 1% of all congenital heart disease.
And the critical moment is when the ductus closes.
Precisely. Symptoms typically begin rapidly after birth, as the ductus arteriosus, which was allowing the right ventricle to pump blood to the body via the PDA, starts to constrict. When it closes, the baby loses systemic blood flow, leading to circulatory collapse, profound cyanosis, and heart failure. It's a true neonatal emergency.
Diagnosis shows.
ECG typically shows marked right ventricular hypertrophy, as the right side is the only functional ventricle. Chest X-ray usually shows cardiomegaly, an enlarged heart. Echo confirms the diagnosis.
And management is urgent.
Extremely urgent. Management involves immediately starting prostaglandin E1 to reopen and maintain the ductus arteriosus, which is absolutely life-sustaining, followed by a very complex series of staged surgical repairs, typically 3 stages culminating in the Font procedure, or, in some centers, cardiac transplantation.
And that wraps up our deep dive into congenital heart disease. Wow, we've journeyed from the incredible temporary bypass system in the womb and those often harmless childhood murmurs to the whole spectrum of conditions, from openings and obstructions that sometimes resolve on their own to these complex blue baby conditions requiring truly intricate, life-saving interventions.
It's really quite a journey, isn't it? And it's truly amazing how diagnosis relies on such a nuanced combination of careful listening during the physical exam, picking up those subtle murmurs or splits,
Yeah.
understanding clues like blood pressure differences between arms and legs, or the response to oxygen, and then confirming and detailing everything with advanced imaging like echocardiography. Each specific detail really helps paint a clearer picture of the heart's unique challenges in these kids.
For you, our listener, we really hope that understanding these specific details offers a much deeper appreciation for the incredible complexities of the human body, how it develops, and also the amazing medical advances that are literally saving and transforming lives every single day.
Indeed. It leads to a final thought, perhaps. Knowing how intricately a baby's heart develops and adapts, and how doctors and surgeons can intervene when that intricate process faces significant challenges right from birth. What does this tell us about the remarkable resilience of the human body and maybe the human spirit, even when facing such profound challenges from the very start?